Yes, ma'am. I think we can start. We have
I don't mind waiting a few minutes if you expect people to join in.
Is it okay?
Yeah.
Okay. All right.
I guess in another 5-10 minutes, more people will join. We can start by 8-10.
Yeah, sure.
Maximum.
Okay.
Yeah.
Okay. So, Dr. Kalpana, whenever you are good to go ahead, please let us know and we can.
Yeah, as a, like 8 to
Sure.
10 minutes. So it is
Sure.
just gone past 8. So 8:10 we can start.
Sure. Sure. So in the meantime, maybe we can have some informal.
Yeah.
Do you have any perspective about pediatric urology training in India?
I have absolutely no idea. No idea. Only because it's been nearly 30 years since I left.
Yeah.
And so much must have changed in that time for the better.
I'm sure.
I do know very few basic things based on the pediatric urology section of USI, for that matter, other discussions, but I don't know the background or how the whole thing functions.
So now that you are a part of IAPS as well, I'm sure you'll get a perspective from IAPS, and then we can compare notes with USI as well.
Yeah. I think the comparison is so far as leaning on the training here and leaning on the training there. So it's nothing, I do not think that certain types of training are bad and certain types are good, because
Absolutely.
One size doesn't fit all. So it has to be catered to the local needs, isn't it?
Absolutely.
But I think I have the benefit of doing my basic training in India, right up to MCH ped surgery. And during that time working in, I did my MS general surgery. So we
would actually love to hear about how you started your journey in India. If it's not a part of your talk, maybe we can have that informally here.
Yeah.
So what time were you in India?
Talk. Yeah.
Okay.
So basically I trained in Bombay, Grant Medical College. And I did my MBBS. Then I did my MS general surgery there itself.
Okay.
And then I did my MCH ped surgery. So I did the MCH ped surgery at the intake of 2 years after MS general surgery.
Okay. And what year would that be? When did you finish your MCH pediatric surgery here?
I finished in 1985 MS general surgery.
Wow.
And at that time, the take into ped surgery was straight 5 years training or post MS general surgery.
Okay.
So then I did my MCH ped surgery and then went to Saudi Arabia.
Immediately after that.
Yeah, we didn't have any money. I was married by then and I had my son and nowhere to stay, no money to invest. So we went to Saudi Arabia as economic asylum, to seek economic asylum. And it worked well because we could buy a flat in Bombay, somewhere to stay.
Wonderful.
Then, ironically, we didn't stay in Bombay. We moved to UK after 4.5 years in Saudi Arabia.
Okay.
And then from there,
if I understand correctly, there was no coming back from Saudi Arabia. You directly moved from Saudi to the UK, is it?
Yes, that's right. Okay. So then we came to UK and I didn't have a job and my husband had a job. And then it'll take few hours to describe the climb.
I'm sure we can have that as a separate talk. I'm sure it will be like very inspiring to know more about your journey sometime.
Yeah.
Wonderful. I think we have decent number of participants now, and it is
Okay, we
8:05.
should start. Yes,
Yeah, and we would, Tanmay?
Yeah, ma'am, I think we have 30 participants
okay.
and
Teacher?
I'll request others to please mute themselves. Yeah. So very warm good evening, and on behalf of IAPS, I am Dr. Tanmay Motiwala, and I would like to welcome our guest, Dr. Kalpana Patil, and who is from UK, and we have Dr. Virender Sekhon, who is from India, and I would like to hand over to Virender ma'am to continue further. Over to you, ma'am.
Thank you, Tanmay. And it is absolutely wonderful to be a part of this Vishwa-Mitra series alongside Dr. Kalpana Patil. I have a brief introduction about Dr. Kalpana, although I'm sure it is not needed and most of us know her already. But for the benefit of the youngsters who've joined, may I read out the introduction that you've sent, ma'am?
Yeah.
Dr. Kalpana is a consultant pediatric urologist in the United Kingdom. And as she was mentioning earlier, her training and background spans 3 countries over 3 decades, that is India, Saudi Arabia, and the United Kingdom. Her special areas of interest include prenatal urology, reconstructive urology, including hypospadias, and developmental anomalies of the renal tract. Dr. Kalpana has a long list of accomplishments to her name. She's been the pediatric urology subspecialist trainer till 2019, post her certificate of completion of training. She's been the educational supervisor and specialist training committee representative for pediatric urological training till 2019. And she has a degree from MRCS and FRCS Pediatrics, as well as FRCS Urological Examiner from the Royal College of Surgeons of England, as well as she's been the Royal College Assessor for Appointment Advisory Committee for consultant appointments. So with that grand introduction, I'm sure you're the best person to tell us about pediatric urology training and regulation in UK.
Thank you, Virender. Pediatric urology training in the United Kingdom, I would like to share some of my thoughts about it. On an average, I think it is reasonably robust, but any system can always get better. So just a little bit of background. Oh, why can't I move? Yeah, sorry. So it was in 1952 that the birth of pediatric urology took place in the United Kingdom. Prior to that, there were discussions and undercurrents of how to make pediatric urology as an independent specialty. And can you see my pointer?
Yes, ma'am, we can.
Yeah. So in this picture, this surgeon is the late Sir David Innes-Williams. On the right is Herbie Johnston. And those of whom may be as senior as me or familiar with the UK pediatric urologist will recognize these names. Sir David Innes-Williams came to India during the World War and gained a tremendous amount of experience in general surgery. He returned to the UK in 1948, and in 1952, he was appointed as a consultant surgeon in Great Ormond Street Hospital. With his appointment came a sea of change on the horizon in United Kingdom for pedurology. And before I move this picture to the next slide, the gentleman in the middle is Peter Kukow, whose name some of you may have heard. Now, there were many founder members in pediatric urology, and it started, the founder members were in Great Ormond Street Hospital, and DI, as he was endearingly referred to, nobody called him Sir David Innes-Williams, he was DI. His professional career spanned from 1952 to 77. And on the right is Mr. Philip Ransley. Many of you may have heard or met him. His career started once DI retired and continued till 2003. So these were founder members. And there were others as well, just to pick a couple of them. Tony Rickwood from Liverpool was a very unassuming, late Tony Rickwood from Liverpool was a very unassuming surgeon and individual. And his attributes were he never flew in his life. He never sat in a car. He only used the trains. So he was an encyclopedia of trains. And to his credit, neuropathic bladder and reflux were his forte. David Thomas from Leeds was also a founder member for Pediatric Urology, and Bob Whittaker from Cambridge, who was the founder or who developed upper tract urodynamics. And Bob Whittaker, with some of the others, started the BAPU, British Association of Pediatric Urologists, and the course which runs annually. So I've just selected a few. So now coming to pediatric urology, what is exactly is pediatric urology in this country? You have to train in pediatric surgery, complete your training, obtain a CCT, which is certification that you have completed the training, and then you move on to a fellowship, a 2-year fellowship. Now, pediatric urology is not an independent specialty, simply because to be an independent specialty, the General Medical Council, GMC as it's referred to, requires a syllabus. Not only that, but the GMC needs to approve the syllabus. Only then it can become an independent specialty. And GMC hasn't allowed that. In fact, on the GMC website, you can see that it doesn't allow any further syllabus formations. So I don't know when it's going to happen, but it will happen. So right now, pediatric urology rests under pediatric surgery. So what is the infrastructure of training in the United Kingdom? There are deaneries, as you may be aware of. There are consortia. I'll explain all these things as we move on in the talk. There are training centers, committees. The trainee gets assessed throughout training. There are quality assurance checks. And for a trainee in pediatric surgery and pediatric urology, there is help at every stage. Not that I've put this slide not because some of us won't know what are deaneries, but in UK, in the National Health Service, there are 20 deaneries, and they are responsible for postgraduate medical training. Now, they fall under local education training boards, and these were established. They were there previously, but they were established in 2013. And these two sit under Health Education England. Now, Health Education England was not formed in 2023, but there was an amalgamation. Health Education England, NHS England, and NHS Digital. And this is a non-departmental body. And this body is responsible to the Secretary of State, which means Minister for Health, and is responsible to the Parliament. Now, the deaneries, they oversee the entire training process, but they get advised by Specialist Training Committee, which is the local committee, and I'll come to the explanation of what exactly STC is a bit later. And the deaneries, they are responsible for the recruitment, for training standards, to monitor the training programs, and educational supervision. They also advise international doctors, and they conduct inspections to the particular department which is training. For example, in Evelina, when pediatric urology had to be recognized as a post-CC training center, the dean with his team came to Evelina, spoke to the registrars, checked all the facilities, and only then approved Evelina as the training center for pediatric urology with certain caveats. And they asked us to put certain things in place, but then came back, ensured those things were in place. Only then we got the approval. So in a in a deanery, when the trainee obtains a training number, which is essential, and again, I'll come to that later. But once a trainee is there in the particular region, they can rotate between hospitals. And this, I think, is a very rich experience, because when they work in different hospitals in their region, they are exposed to multiple clinical settings, and they have a broad exposure to a wide range of specialties like pediatric nephrology, prenatal urology, transplant surgery, and so many other facets. And also, because they move sites, they establish relationships. They get to know different people in multiple sites, and they also learn more about particular subspecialty. So I think rotations in a deanery, in a region, is an extremely useful thing, because I did that, and it was truly an experience. So I rotated St. George's Hospital, Great Ormond Street Hospital, and Southampton Hospital. And I really enriched myself with pearls, as the consultants were known to drop pearls. So what are consortia? Consortia, they're a group of medical schools and teaching hospitals. And with the subsequent slide, it might be easier. These consortia, there are boundaries made based on geography and the specialties that are provided. They are not political. Politics doesn't play a part in these consortia formation. There are 6 consortia in the UK, and once the trainee gets a training number via national selection, according to their personal needs and training needs and their choice, they select a consortium. And these are the consortia. So I'll take you through, because this is quite a busy slide. On the top right hand, the key is this 6 consortia. So the yellow, Southeast, if you take that and come to the map, here, the whole of Southeast has got 11 hospitals. Not only that, in London, there are 6. And if you come here with me, this is the River Thames. So there are literally 3 north of the river, 3 south of the river. But in these hospitals, it's only Great Ormond Street Hospital north of the river, and the Evelina Children's Hospital, London, south of the river, are pure independent children's hospitals. So the Southeast is the biggest consortium. So if a trainee is in the Southeast, they can rotate any way they would wish to in ped surgery. In pediatric urology, I'll come to later, they do a certain different rotation. And then if you go to the northern, which is the black, there are 6 centers here for training. Up in Scotland, there are 3, Glasgow, Edinburgh, Aberdeen. Manchester and Liverpool are together, and then Birmingham, Bristol, and Cardiff. So these are the 6 consortia based on the geography and the specialism that is offered. So the bigger consortia like the Southeast can offer the trainees a rich experience in specialism. I hope this makes sense. So then, as I was just saying, the larger consortia provide rich experience, but the smaller centers, they take junior trainees, and equally, they have an equal role in training. So once the trainee is posted or selects a consortium, sometimes demands of personal needs and training requires that the trainee makes lateral move to another consortium. And that depends on the training program director who sits in a hospital in a specialty. So it is possible to be flexible. Now, what are the committees involved in training? The Joint Committee for Surgical Training, referred to from now on as JCST, is the parent body. It's an advisory body to all the 4 Royal Colleges: Royal College of Surgeons of England, Royal College of Edinburgh, Glasgow, and Ireland. So it's an advisory body to all the 4 Royal Colleges. Then there is a specialist advisory committee. There are 10 of them, and they're specific to the specialty. This specialist advisory committee works along with JCST, but also with BAPS. So there's a BAPS representative on this advisory committee, and it works along with Health Education England via the training program director. So they are all interlinked committees in delivering training and monitoring training. And STC is Specialist Training Committee. It is a local committee which meets every year to assess the trainees via annual review of competence progress. And I'll come to further explanation for that. So these are the main committees. This slide is to just explain, this is the core training in the Southeast region. And you can see the hospitals here and the specialisms they provide. So if I take you to Evelina, it has got urology, upper, lower GI, thoracic, neonatal, all the specialisms. There are 4 training posts, 4 senior clinical fellow posts, and 4 SHOs or fellows, clinical fellows. And you can see in Great Ormond Street, you have oncology as well. And Evelina has acquired a big oncology service only recently. So Evelina will have the oncology as well with time. So what is pediatric urology then, if it's not an independent specialty? So pediatric urologists are pediatric surgeons or adult urologists who have subspecialized in pediatric urology. And to be able to do that, pediatric surgeons need the CCT in pediatric surgery, and so do adults in adult urology. However, the adult urology candidate needs to spend 1 year in pediatric surgery after their CCT to recognize an ill child, and how to manage an ill child they need to know. But the majority, the urologists, adult urologists are far and few entering the pediatric urology program. Majority are pediatric surgeons. Now, one second, sorry. Yeah, the pediatric urology training started quite some time now. And the pediatric surgery or adult urology trainees, they are given a unique national training number when they choose the consortia. And this unique training number recognizes the trainee across all consortia and deaneries. And in pediatric urology, there were 6 NTNs. These were recognized by SSE. Remember, SSE is Specialist Advisory Committee under the auspices of Joint Committee for Surgical Training. And it was open to both ped surgery and urology. And it was funded by the host deanery. So if you see Birmingham, Leeds, and Manchester had 1 post each. In London, there were 3 posts, one in Great Ormond Street, one in Great Ormond Street Hospital, one in Evelina London Children's Hospital, and one in Southampton. And in London, we had decided that because of the complexity of work in Great Ormond Street Hospital, all post-CCT fellows in ped urology will do 1 year in Great Ormond Street and an other year in Evelina or Southampton. And subsequent to this, and the finances have changed recently, and the money comes from a different bursary. And few more posts have been added, like Nottingham, etc. But the training continues in pediatric urology as 2-year post-CCT fellowship. So in terms of time, what does it mean? FY is foundation year, and it is part of the medical school training. At the end of it, you do 2 years of foundation training. Following that, you do 2 years of core training. Foundation year is very basic. It's a salaried job. Core training is the essential training within the specialty. And after the core training, you enter specialist training for 6 years. Once you finish your specialist training in 6 years, you get a CCT, completion of training, following which you apply for the post-CCT fellowship in urology for 2 years. So if I got my maths right, it takes 12 years to be able to qualify, practice as independent consultant pediatric urologist. Not that. You then apply for a consultant job, and depending on the available opportunities, you'll become a consultant pediatric urologist. Now, when DI started, a few years later, in the 70s, there were 6 pure pediatric, I prefer to call it as pure pediatric urologists. And now there are about 45. So it's only a 7-fold increase in maybe 7 decades or so. So the 6 years of higher surgical training, this is in ped surgery, can start with an uncoupled program. What does uncoupled mean? The trainee applies for jobs at every change. So it's competitive. On the other hand, there is a run-through training, which is coupled, which means they apply only once and go through their complete training. This is available for clinical as well as academic. So the trainees who are highly academic oriented go out, do whatever they need to do in their academics, clinical academics, and then they come back into the system without having to apply. At the end of 4 years of a little bit more generic but specialist training, you are eligible to sit the FRCS PED or intercollegiate exit exam, as it's called in UK. But to be able to sit the exam, your supervisors have to give the permission, and that is based on how ready you are really. And the next 2 years, the trainee focuses on areas of interest and then obtains the CCT. So most of the pediatric urology consultants in UK are members of the British Association of Pediatric Urologists, BAPU, and it's a body for ongoing education, research, support, discussions. And we meet annually every September. And it is along with the BAPU course, which the founder members started in the 1990s. And the course still runs today. And ped surgery trainees and adult urology trainees take that course before taking the exams for revision. I took it, but in 1999. Now, the eligibility to become a consultant, you have to be on the specialist register of the GMC, which you apply for after your CCT. So to apply for a consultant position, you need to be on the specialist register or within 6 months off, which means if I was going to be on the register in December, I can start applying after June. The appointments are via open competition and interview with an AAC, which is Appointments Advisory Committee, which the local trust or hospital sets up. And what is AAC? AAC is a legal requirement when appointing consultants. The function of the different members is to ensure that the applicant fulfills the job description and is best suitable applicant among the interviewees. And the AAC panel as I said, is a legal requirement, and no appointment can take place without this panel. So who's on the panel? There's usually a lay member. There's a Royal College representative, and I've fulfilled this role and continue to do this as a college assessor to ensure standards that the trainees are on the specialist register. The job has been given to the best trainee, and the trainee fulfills all the requirements for a consultant pediatric urologist or pediatric surgeon. It also has the chief executive of the employing body or hospital, the medical director, consultant or consultants from the relevant specialty, and a university representative. So these members make up the AAC panel. So probably gone are the days when a phone would be picked up by one consultant telling the other consultant, please give this particular trainee a job. I mean, going through all these things, that becomes a remote, is not a possibility in my experience. Now, the JCST, as I said before, is an advisory body for the 4 Royal Colleges, and it's the parent body for the SACs. Now, what are SACs? They're advisory committees, and there are 10 of them for 10 specialties. And they sit on the trainee review and assessment committee. They sit in an advisory role on other committees as well. And very importantly, there is an intercollegiate surgical curriculum program. So JCST advises them as well. And I'll come to the ISCP. So those were the committees. So we did deaneries, consortia, committees. UK training was very proud to say that it is competency-based, not time-based. So a trainee in year 4 is not going to go automatically to year 5 and 6 unless they show competency. But then there was a criticism that it is very heavy on competency. So what should we do? So there was introduction of the surgical curriculum not so long ago via the intercollegiate surgical curriculum program. Now, this didn't happen overnight. The General Medical Council decided to set new standards via ISCP. And they did it following a detailed consultation process, which involved the trainees, the trainers, stakeholders, NHS employers, patient and lay groups, experts in curriculum and assessment design. So the whole lot opinion was taken from all of these. And then what happened? So then they came up with general professional capabilities and capabilities in practice. Now, capability is a set of skills someone is capable, which can be learned from the novice till the expert stage. And when capability is applied to higher clinical outcomes, it's called capabilities in practice. And general professional capabilities, I'll show you, are certain domains and skills. So capabilities in practice, the trainee goes through 5 capabilities in practice. These are generic to all specialties, and specific to ped surgery is management and assessment of sick neonates and pediatric patients on the PICU, how one conducts interpersonal skills, discussions, how to overcome uncertainty in management, all that for neonates and PICU. So the 5 domains are all aspects of outpatient setting, emergency setting, inpatients, operative treatment within the specialty, interdisciplinary management, multi-consultant input, when to get another consultant opinion, another specialist opinion within the specialty. So these were capabilities in practice. Please keep this in mind because there's a slide which integrates all this. general proficiency framework looks at professional skills, research, education and training, patient safety, team working, health promotion, illness prevention, understanding the system, understanding NHS. These are the professional skills and professional knowledge of the specialty, and professional values and behaviors, teamwork, respecting colleagues, valuing opinion, and working in a team. So these are general professional capabilities. Now, this was the picture that I wanted you to remember what CIP meant. It is capability in practice, and GPC is general professional capabilities. So in the syllabus for a specialty, if you take general professional capabilities, which is knowledge, skills, and behavior, and if you look at individual aspects of that, these are called descriptors. And when these descriptors, if you take the syllabus and these general professional capabilities, you form small tasks. So these tiny, tiny circles are small tasks. And I'm keeping it generic rather than going into the specialty. These are small tasks, and groups of small tasks provide descriptors. And they go towards formation of capabilities in practice. So like capabilities in practice 2 is emergency medicine. So all the little descriptors in emergency medicine, recognizing a sick child, managing uncertainty. It's not clear what the diagnosis is, what to do, making a diagnosis, contacting your consultant, working in the team. All that goes towards formation of capability in practice, and the 5 domains, as we just said: outpatient, emergency, operating theaters, etc. These are generic, and for ped surgery was neonates and PICU. And if you take these small tasks and capabilities in practice and combine it with general professional capabilities, you form the capabilities in practice forms the constituent parts of a consultant. And these constituent parts, when you combine them with the general proficiency, it goes towards formation of a consultant surgeon. And these capabilities are learned through training from the very basic till maturing in your year 6 of specialism. So consultant surgeon is not just knowing the art. The other aspects have to be there. And it's not just that this is set in the training and that's about it. It is looked into, and the consultant produces a report. MCR is multiple consultant reports. I hope I've taken you all through, but do ask me in discussion if you've not followed it. Now the trainees, how do we do the assessment? So there's an ARCP, Annual Review of Competence Progress, and it has got a panel. So the Annual Review ARCP meets the STC, the Specialist Training Committee, which is responsible for local training, meets once a year on the same day as ARCP. It has got 2 functional plans. In the morning, in the AM session, the STC members, who are the assigned educational supervisors and other trainers as a hospital, they meet. The trainees have already provided their portfolio and discussion takes place. There's no face-to-face trainee over there. But sometimes trainees are invited. If there has been some difficulty, there's been some bullying, there's some concerns in training, they are invited to put their case in front of the STC. And in the afternoon is the ARC panel, which consists of a member of JCST, an advisor from SAC, representative from the deanery, academic representative, external representatives, and lay representatives. So in the afternoon, it had been face-to-face prior to COVID, Post-COVID, it is remote. And the trainee has to take a very active part. They have to provide the local educational supervisors structured reports, the MCR, via the curriculum program, which is online, their logbooks, their portfolios, and an updated registration form as well. So trainees submit this. So the assessment system is portfolio evidence, then the discussion in the STC. But in the portfolio, apart from multi-source feedback, various work-based assessments, trainee self-assessment in those domains, capabilities in practice, general professional capabilities, and the exams, and the multiple consultant report goes to the assigned educational supervisor's report. So assigned educational supervisor is only one. And with that report goes to the ARCP committee. And in the committee, there's a discussion whether this trainee can progress from the current year to the subsequent year, if everything is satisfactory. If not, and for that, they need to score 6. If they score 6, it is satisfactory progress. If they score 4, they need targeted training, they need help with the training, and they need special placements. So all that is discussed in the ARCP. So these are formative feedback assessments, 1, 2, and 3. These are formative assessments, the trainee does it, and these are summative assessments. It's quite rigorous and thorough. So the multiple consultant report and learning agreement are the tools. So if you come to the bottom of this slide, if it's a 1-year placement, at the end of the 6 months, there is a midpoint multiple consultant report. And then in the 7th month, there's a learning agreement. Simply, the learning agreement is Mrs. X requires more focus on prenatal urology and hence should spend some time in the prenatal department and King's Health Partners. Then the trainee also has a say. Trainee will say, oh, I need to do more complex operating. So that is the learning agreement, but it is not a wish list of the trainee. It has to be agreed with the supervisor and the consultant with whom you're working. So there is a midpoint consultant report, midpoint learning agreement, final consultant report, and final learning agreement. And this is all documented. So the sequence of assessment is that there's a learning agreement in the first half of the placement. So if this placement is for 6 months, it's 3 months and 3 months. If it is 4 months, it's 2 months and 2 months. So there is a learning agreement at the start. And during that learning agreement, the trainee brings in the multiple consultant report from the previous position. And then the learning agreement is decided. And in the second half, again, you have a final review of the learning agreement and the consultant produces a multiple consultant report. So clinical supervisors meet their trainees to agree the multiple consultant report. Any consultant who is a substantive consultant is a clinical supervisor, CS, but AES, assigned educational supervisor, is only one. And the trainee meets both and plans are made for their subsequent postings or positions. So that was, without going into too much details, the training pathway and the requirements. But how do you quality assure? Now, the standards for designing and developing the postgraduate medical curriculum lies with the college and other organizations. However, no program, training program, is complete without GMC approval. So GMC is at the top of approving any medical program or curriculum. And how it is managed and implemented, it is implemented via deaneries, local education training boards, and the local providers, the centers. So it is very well quality assured. And now we have something called less than full-time training. Previously, this was referred to as flexible training, but now the terminology has changed. So a postgraduate trainee does 40 hours per week. That's called 100% full-time. But due to personal needs or any other reason, trainees have the legal choice of working less than full-time, 60 to 80%. What that does is their training period prolongs, but then it suits their lifestyle or their needs, both on a professional and personal basis. Now, in UK, the trainees have a support program, as I was referring to. There's continuous support for anything and everything. So if a female trainee goes on maternity leave, she has certain rights, and all these are written in black and white. And she doesn't come back from maternity leave straight to where she left. She is phased in. She reintegrates. If there's been a long sickness, similar things. If the annual review of competence progress has got a poor outcome, then you repeat the year. But all that is planned. And also trainee in difficulty. Trainee in difficulty is if they're not punctual in their attendance, if they do not keep their portfolio, they are not motivated, there's a gap in their knowledge. It's a low-level concern which can be addressed in the department itself. If these concerns become persistent, it becomes intermediate. And high-level concerns are when there are serious issues and the General Medical Council gets involved. But even for training in difficulty, there's various things placed in position to help them through the process as to what they need to do. Just a few slides about exams. These are not, they're expensive. The ped surgery exams cost 1,900, and the MRCS, which you take before that, is 1,500, and you're allowed to take the exams 4 times. Too expensive, better to get it out in the first attempt. Again, exams are thoroughly regulated. There is a joint committee on intercollegiate exams. All the exams, MRCS, the FRCS, have now become intercollegiate exams of all the 4 Royal Colleges, referred to as exit exams. And believe me, like the ped surgery, the part 1, the single best answer MCQs, the MCQs to come up in an exam goes through a humongously rigorous process. So it is extremely well regulated. MRCS, you'll be familiar, it's an MCQ and a clinical exams. The clinical exams is objective structured questions and stations. Now, the overarching regulatory body is the General Medical Council. This is an independent body completely responsible to regulate doctors in the United Kingdom. You don't want to get into the bad books of GMC. No. It's a statutory body. It's responsible for the medical register and for doctors to be put on the register, for the standards for education and training, and more recently for revalidation. And it came into legal action in 1983 following a medical act. So the medical register, the GMC checks the doctor's identity completely and qualification, also gets input from the doctor's previous employers if there were any concerns about the doctor to practice safely. And not only that, it keeps tracks of the doctor's changes and records them on the register. So it is updated, all the details of the doctor. Since 2012, 14 years ago, 12 years ago, they introduced licensing and revalidation. This is separate from the registration, which I just referred to, getting onto the register. Licensing, they issue a license to practice. And revalidation is, once you're on the register, obtain a license to practice, you need to show continuation of progress. And you get revalidated every 4 years. I just had my revalidation a couple of weeks ago. And finally, the NHS long-term workforce plan, which is a brilliant idea if it works well. It was published last year, and for the first time in the history of National Health Service in UK, there was a plan to see where we are on the National Health Service now and where we need to be. Not just identifying where we need to be, but where will the finances come from as well. So hold your breath if this works. So finally, the pediatric surgery and more so pediatric urology training in the United Kingdom has a robust infrastructure, has continuous monitoring and assessment, is very well regulated, has systematic changes. They don't happen overnight. They are thoroughly studied and assessed. And there's review of progresses as regularly and as and when required. And this is just a bit in London. The training program director has started SKIPS, which are skills in pediatric surgery. It's only for London trainees. It's a validated tool of the OSCE type. It's a face-to-face annual meeting where the trainees are expected to do at least 4 out of their 6 years of specialist training. The trainees have workstations, discussions. They are assessed, scored, and ranked in terms of the stage where they are and where they should be. And trainees tell me that this is quite useful. Thank you. Can we stop the recording now, please? Because I want to show a slide, but I don't want it recorded.